Non-tuberculous mycobacterium. Non-tuberculous mycobacteria, also called atypical, opportunistic, and environmental mycobacteria, are found in the environment, including in soil and water, and may cause disease in susceptible individuals. They are divided into rapid and slowly growing species for clinically relevant examples, and NTM are less virulent than MTB, and unlike Mycobacterium tuberculosis, are unable to adhere to intact undamaged airway mucosa. Risk factors for non-tuberculous mycobacterium diseases include chronic lung disease such as cystic fibrosis, bronchiectasis, chronic obstructive pulmonary disease, cavitary lung disease secondary to prior tuberculosis, immunodeficiency such as HIV organ transplantation, anti-tumor necrosis factor alpha therapy, rare genomic or genetic mutations in interleukin 12, interleukin 23, and interferon gamma signaling autoantibodies against interferon gamma. Gastroesophageal reflux disease, pectus excavatum, and kyphoscoliosis may be risk factors. Non-tuberculous mycobacteria disease is well described in otherwise healthy, thin, tall, middle-aged women. The pathogenesis is obscure, although one hypothesis is habitual, voluntary cough suppression, leading to failure to clear airway secretions, so-called Lady Windermere syndrome. Clinical features of NTM or non-tuberculous mycobacteria include non-specific symptoms such as chronic productive cough, fatigue, sometimes weight loss, dyspnea, fever. Often complications are known underlying lung disease such as chronic obstructive pulmonary disease. Colonization of abnormal lung may not cause symptoms but can progress to cause disease later. Disseminated infection may occur in immunocompromised patients. Hypersensitivity pneumonia secondary to non-tuberculous mycobacteria may occur following use of hot tubs, indoor swimming pools, or contaminated metal walking fluids. Breathlessness tends to be a prominent symptom. Investigations include chest X-ray, sputum sample microbiology for acid-fast bacilli, stain cultures, and further identification. Bronchoscopy, high-resolution CT just typically show thin-walled upper lobe cavities with marked pleural involvement or small nodules with tree-in-bud pattern and cylindrical bronchiectasis or bilateral diffuse ground glass infiltrates. Diagnosis: distinguishing contamination or colonization with NTM form from clinical disease may be challenging. A single positive NTM sputum culture is unlikely to be of significance, although such patients should be followed up with periodic sputum cultures. Management: the decision to treat is complex. No need to notify or contact trace. Typical drug regimen for specific non-tuberculous mycobacterium species are described or prescribed according to the exact or specific non-tuberculous mycobacterium. As for example, in Mycobacterium avian complex, the treatment will be clarithromycin or azithromycin, rifampicin, and ethambutol. Then Streptomycin IV can be given. Also, in Mycobacterium cancersis, the treatment will be rifampicin, ethambutol, and isoniazide. And chlorothromycin and moxifloxacin may also be useful. Mycobacterium malamensis, the treatment will be rifampicin, ethambutol, and macrolide for at least 12 months. Should avoid macrolide monotherapy. We should be alert to the possibility of drug interaction. And the curative therapy is not always possible, reflecting antibiotic resistance in the NTM species.